Hi, everybody. This is Dr. Rick Lehman, and tonight we're in your corner with CORA, and we have truly one of the best topics that we have had so far in these podcasts, and we're going to talk about robotic total hip replacement, and we have truly an all-star cast. So I'm going to let Dr. Dan introduce himself, and we're then going to introduce Mr. Yaz, and then we're going to jump right in after that. Dr. Dan, you're on.
Hello, my name is Dr. Den with Optomotion Orthopedics here in Orlando, Florida.
Well, it's a pleasure to meet you guys as well. My name is Talha Riaz. I'm a physical therapist with CORA Physical Therapy in Orlando CORA Spine Center.
So day two, patient comes into the clinic and they say, Mr. Rees, when can I drive? You know, my wife doesn't drive in the city, and we ran out of groceries, and because of COVID, we're starving to death. Well, when can I drive? What are you going to tell that patient?
Well, one of the main things that we want to make sure that it's usually between week 3 and 6 that we can actually sit a little bit more on that 90-degree angle. Usually we're starting them at a recumbent bike, which is slightly reclined to obviously protect the hip. So that's some of the conversations I'm going to have with the patient. I would want them to wait at least between, at least 6 weeks to make sure we're protecting that joint, but also that they're able to comfortably take a reclined position, maybe in the chair or in their car. But definitely our first focus between those first 6 weeks is to protect that joint. So if that's going to be an issue while they're sitting in the car or actually transferring out of the vehicle, we want to make sure they're not twisting it at the hip joint as well. So again, protecting that joint becomes the priority.
Thank you. Dr. Den, between the anterior approach, posterior approach, and lateral approach, give us the precautions for each approach to the hip. What are you telling your patients who've had a posterior approach? What can't they do? What are you telling your patients who've had an anterior approach? What can't they do? And a lateral approach, what do you not want them to do?
Yes, so start out with a posterior approach. The biggest risk of posterior approach is dislocation. So what they cannot do is, for me, if I ever go back and do posterior again, it's going to be no flexion more than 90, no internal rotation, and that's probably the biggest thing. And then you have to use the abduction pillow while in bed. And for the lateral, the biggest risk is limping because you detach the anterior third of the abductor. And because of that, your abduction is weak. So for me, it's no abduction for 6 weeks. And for anterior approach, the reason why I love it so much is I don't take down any muscles. So actually no precaution for me at all. And rehab for my anterior patients are a lot different. They walk the same day, they go home the next day, no hip precautions. They typically will get back to golfing and sport activities at 6 weeks. So that's my goal for all my hip patients that I do is 6 weeks get back to all the sport recreational activities.
That's awesome. Thank you.
That's super awesome.
So, Dr. Den, is there any specific complication in a robotic total hip that you normally would not see in a conventional total hip? So you would see potentially that's something that's specific to robotic total versus a conventional total.
Yes, with the robotic total hip replacement, you have to put the pins to put the tracker in, so the robot will know where the patient's hip and pelvis is within the three-dimensional space. So those pins, after they've been removed, it can be a site for infection. So pin site infection is one of them. As far as other complications, it's very similar to the conventional total hip replacement. It's depending on what kind of approach you do and stuff like that.
So we're going to wrap up a little bit. This has actually been excellent. Again, I think everybody is intrigued about technology, right? You got your iPhone 11, you can't wait for your iPhone 12, and your Tesla, and you guys are all, millennials and doing all this stuff. So big question, if you have a preference versus, and I think you voiced your preference, but if you have a preference, conventional, perfect patient, sounds like you want to do an anterior robotic total hip replacement. Like you said, walking the same day, really no precautions. And really, when I see these pages, I'm a sports guy, so they're coming in with a torn Achilles or a torn rotator cuff and they're telling me how great they've done. How many in a year robotic total hips do you think you do versus conventional total hips? And the second part, again, a little disjointed, what sports the athlete or the patient's going to come in and they're going to say, can I play tennis? Can I play basketball? So what sports can they safely do in the ideal patient who's had an anterior navigation assisted robotic total hip versus a conventional total hip? So how many do you do, and what's your preference, which I think we know what your preference is. Tell us, and then kind of tell us your what are you going to, the first visit, Mr. Jones wants to go out and play pickup basketball. What sport can he ski? What can he do? What can he do?
So for me, I looked over last year, it's actually about 95% robotic total hip replacement. The other 5% are actually, I'm still taking trauma calls. So the other 5% are my hip fractures patients that required hip replacement. And because I cannot get CT scan on time within that 24 to 48 hours window to get it done safely. So my preference is the anterior total hip replacement with the robotic arm assistance. And in terms of return to sports, here in Orlando, there's a lot of retirees and they love pickleballs and golf. So pickleball and golf is safe. Softball is safe. The only thing is within the first 6 weeks, I probably won't let them do any yoga. And of course, ballet. There's absolutely no ballet because it's got you're at high risk of dislocation more than anything. But pretty much you can. It's not like a total knee. The total hip is a very good procedure, very good patient satisfaction, and they typically can go back to their normal activity very quickly, and also sports activities as well.
I lied, so I'm gonna ask you one more question. Guy comes in, had a total hip replacement 13 years ago, 15 years ago, lytic lesions in the calcar, obviously needs a revision. Is that patient a candidate for a robotic? Can robotics be used in a revision, or is that strictly conventional? And again, what approach do you use?
Yes, so a robot can be is a good candidate. Let's restart. The patient is actually a good candidate for robotic hip replacement because with a CT scan, you understand the lytic lesion very well. And I use the robot quite a bit with patients who had a prior acetabular fracture after fixation as well, because now I can remove bone up until that screw and not hitting that screw. So that's the coolest part. And I just rest the cup up there and place my implant. So the CT scan and the 3D model will allow me to have a preoperative preparations in advance and know exactly what I'm dealing with before I operate on the patient. And as far as the approach, for a patient that require a cup, an acetabular or cup revision, usually I can use the anterior approach. If it a short stem that I can put in for the femur, I can do it anteriorly. But if it's a longer stem, I would use the lateral approach.
Thank you. So I'm going to give each of you guys a chance to kind of wrap it up. Anything you haven't covered that you want to say that we'll add in. So
Absolutely. I mean,
yeah,
to say
give it a go, and then Dr. Den, anything you think that our listeners should be added to this information. You're on.
Well, definitely, I'd have to start off with saying that I'm definitely curious to know how this proceeds into the future when it comes to therapy in the future as well. I mean, I'm definitely surprised to hear, Dr. Dan, you were mentioning 6 weeks, which is great to hear, considering I have a lot of patients that are, always asking that question, when can I get back? So it's one of those things that I'm seeing these surgeries evolve, and I'm really curious to know how we'll be able to kind of change the future with the contraindications, especially. Dr. Dan, I had a question for you, especially when it comes to these contraindications, specifically the posterolateral approach. Have you found that by using the robotic assistance that their contraindications are not as prolonged as they usually traditionally would be with the conventional THA?
For the posterior hip replacement,
Yes, sir.
yeah. So it's the biggest advantage with the posterior lateral approach is you see everything, and then now with the robot, you can place the cup exactly where it's supposed to be. So instead of having a little retroverted, now you can have it anteverted exactly at 15 degrees. Maximize your all parameters, so that risk of dislocation is a lot less with the posterior lateral approach. And so for me personally, with my hips, usually I don't really send my patient to formal physical therapy too much. I do send the patient at 6 weeks if they have abduction weakness from the lateral approach. Or they're walking with a Trendelenburg gait that needs some gait training. If they have quads weakness, then I'll send to PT as well. Especially the one that I see the most are actually very severe hip replacement with dysplastic hip, where the one leg is much shorter than the other, and now I lengthen the leg, and the patient, it'll take some time to get used to that kind of gait and walking normally without a lift again. So usually those patients will be a very good candidate for formal physical therapy.
Very cool.
Thank you. Dr. Den, any closing thoughts?
I think we cover everything. So thank you for having me tonight, and it's kind of fun to speak and meet with other people as well. So,
well, listen, you guys were both great, and seriously, it's a great topic, and obviously this is where arthroplasties are going. I mean,
absolutely.
Some of them will listen, some of them won't. It's for some of these patients will say, what about a Tommy John surgery? I say, why don't you listen to this podcast? So again, you guys, thank you. You were both awesome.